Steve, over to you.
Thanks, Andy. Just check people can hear me all right. A bit of a thumbs up from someone. Sarah? Yep, good. All right, jump on to the next slide. I'll be pretty quick. So a quick update, as you guys know, registry has been running for a while now, so we're off and running. There's been a whole lot of work that's gone on in the last 4 months, still going on. So what we've done already, we've established the registry, we piloted it, it's up and running, governance is in place on it. And then the really awesome work from the teams came in where we collected baseline data. So this is onboarding data around the profile of our patients. And we've got about 2,000 patients of data entered, which is a really quite a big effort and a lot of new information that was previously very hard for us to analyse and gather together in one place. And then at the end of March, obviously the quarter ended, and during the period of April and a little bit of an extension, we then asked the teams to go and then to reflect on the first 3 months of the year and enter data around things like emergency department presentations, hospitalizations, falls, etc., medication use. As you can see, we didn't quite get every patient that was onboarded to be collected in that, and that's partly to do with some staffing reasons as well. But still, 1,500 patients where that data, which is what's being analysed now, is quite a valuable resource. We've been crunching a bit of that, and I'll share a bit of that with you today. We also, as Andy mentioned a minute ago, we've submitted for publication some data, indicative data that we collected last year, throughout 9 months of last year, and also putting that towards a poster presentation with the geriatrics conference coming up in June. So we're getting our message out there based on what we've already measured about ourselves, but the registry measures quite a lot more and will be more of a conveyor belt of news and information and results coming out going forward. And we've also been invited to join with SAMRI, that's the South Australian Health and Medical Research Institute, who are really leaders in aged care and older Australian research. And they're putting an application in for grant funding for a project on optimal workforce configurations for the aged care sector. So clearly our model is of significant interest to them, and they're going to be studying that if they get that grant successful, which we're hoping they do. So at the moment, work that's going on, and literally I'm doing it right now, is crunching the first pass of some of that data that we've collected. We're also putting that, how do we use this data in a quality assurance method, a feedback loop that will be coming through soon. We're also totally very aware that there's a lot of manual data being still done to get the registry working, and smarter ways to do that are being explored. And Steve and Jess have been working on I guess a prototype of a different way of how our teams can be supported in Queensland at the moment. And we'll see how that goes and what we learn from that, and we'll implement that for the next quarter. And as I said before, we're waiting to hear back from our journal. What's coming up next is we really want to work out what those changes are and put it in time so that when we get to July this year, we have still a manual method, but more efficient use of how people do that task. We really want to have that internal QA dashboard in place. We're also going to do a much more closer analysis on what we can automate so that we can reduce or remove as much of that manual data entry as possible and reduce the burden on the team. So sort of think about it this way. We've started the registry by collecting it using manual methods. This is people typing things into a system, but we're already beginning to improve how we do that. So the goal by the end of this year is to have the most effective way for us to collect the data that we can analyse as possible. So you jump to the next slide, please, Sarah. So a little bit of a few snippets here of what we've gathered. Out of 39 sites that were included in the original scope, we ended up collecting baseline data for 32 of those sites, and those that didn't get data collected were really due to some staffing changes that interrupted things. We're going to work on that soon. Of those 32 sites, 29 were able to completely enter the data for their Q1 for their patients. And I mentioned the data before as to how many we've got. So it's not a perfectly a coverage as we'd like to have, but it's an excellent start. If you look at the majority of what we aim to do, we still have got the majority of it achieved. On the right-hand side, no surprise, I'm sure, to many people, but the average age of our patients is quite old. Average age is 85 years old. More than half are over 85. a skew towards a female population. 2% patients identified Indigenous, and 91% reported English as their native language. So this kind of just demographic profiles gives us a little bit of a snippet as to what the patient population looks like. If you jump to the next one, Sarah. We also gathered a fair bit of information around the conditions and diseases that our patients had. Two types. One on the left-hand panel here are diagnosed medical conditions where we could find the diagnosis was entered in the record. And the right-hand side, just call them geriatric conditions. These are ones that were noted, but not necessarily a clinically diagnosed condition. Important to see on the left-hand side there, hypertension, dementia, depression, anxiety, really high prevalence. But what's probably most relevant here is that many of our average diagnosed condition per patient, 3.7. So 70% of our patients have more than 3 things going on. 27 of them have more than 5. Some of those conditions like heart failure and COPD are really known to be exacerbated, requiring hospital and ED presentation. So the upshot of what this slide really tells us is that we have quite a high complex patient cohort that we're managing. And this is, remember, from nearly 2,000 patients. So it's a really strong representation. It's unlikely that this data would be different if we collected data for every single one of our patients. It's giving us an idea that the acute, sometimes the term acuity is used. These are high acuity patients that we're looking after. And it's no surprise that they need hospital care and etc. And as mentioned before, the value of preventative care in these patients cannot be underestimated. Heart failure, as an example, having actively managed and medications optimized for heart failure patients is clinically proven to improve outcomes, but to reduce their events of hospitalization and burden on the system. So this is telling us that we've got lots of these patients who have plenty of opportunity for us to do that preventative care really, really well. If you jump to the next one, please, Sarah. Different topic here. This one is really about how we are implementing our own plans and planning and things that we want to be able to do in terms of assessments. So on the left-hand side, palliative care assessments, not as many as we'd like. So still the majority of patients haven't, according to the records that we've got from the registry, haven't had a palliative care assessment done yet. Of those that do, again, observing that most of the patients are considered to be low in terms of their needs, which is not surprising. And on the right-hand side there, which is good to see, 73% of those patients that had an assessment done, we did record goals of care. The right-hand side, with more of administrative things, is an advanced care directive completed for the majority of our patients. The answer is yes. Again, some of these things, Narelle and I have been discussing how we record these ongoing and feed it back to the team so that we can basically drive these numbers up to as close to completion as possible.